Hello and welcome. My name is Colin Peckrin, and I'm a program director at Grantmakers in Health. On behalf of GIH, I am pleased to be introducing this important conversation on creating resilient, equitable, and age-friendly communities. COVID-19 has shown a bright spotlight on many deficiencies in our care and support systems, ranging from equitable access to nutritious food to any other number of important social services and supports. While many of these challenges have existed long before the pandemic, they are issues that are growing harder and harder to ignore. Older adults are perhaps the population who have been hit the hardest by the pandemic, and many communities have been working hard to provide the necessary care and services that they need. While many providers and funders are feeling a bit overwhelmed by these challenges, the good news is that there are solutions. And today, we have the pleasure of joining a conversation that will dig into not only some of these pervasive challenges, but also the solutions, including the evidence-based capable model. So today we have the pleasure of being joined by two distinguished guests, Dr. Sarah Szanton and Mr. Andrew Levack. Dr. Szanton is the Health Equity and Social Justice Endowed Professor and Director of the Center for Innovative Care and Aging at the Johns Hopkins School of Nursing. She also holds a joint appointment in the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. There, she tests interventions to reduce health disparities among older adults, where her main research strands are aging in community, the effects of financial strain on health, and structural racial discrimination and resilience. She co-developed the Capable program, which she has been testing in randomized trials and scaled to 34 new sites in 18 states. She was also a 2019 Heinz Award winner for the human condition and is a PBS organization's Next Avenue Influencers in Aging. She has published more than 140 papers and been principal investigator on more than $20 million in grants. Mr. Levack is Senior Program Officer at St. David's Foundation in Austin, Texas. There he develops strategies for programs and grants around aging in place, which has included collaborations with Dr. Szanton. He has a Master of Public Health from the University of Washington and holds a clinical faculty appointment at the University of Washington's Global Health Department. Andrew also serves on the Board of Directors of Grantmakers in Aging. Sarah, Andrew, welcome.
Thank you, Colin. It's such a privilege to be a part of this conversation with Sarah. And thanks everyone for joining us over this format. Sarah, I wanted to start our conversation by a reflection really around your origin story. You know, one thing I've really admired about your research is that it's informed by your time as a provider, as a nurse practitioner who worked with older adults in home settings. And I wanted you to first kind of share some thoughts about some of the things that you learned as an advanced practice nurse working with homebound older adults in their homes.
Thank you, and it's such a privilege to be here with you, Andrew. I would do anything to be with you, and to have the platform where we get to speak with other people is really wonderful. So thank you. Yes, everything that I do is grounded with people and patients in mind. And actually, my first nursing job was with migrant farm workers who lived in converted chicken coops. And my second job was working with homeless adults or people experiencing homelessness. And then my third clinical job was with providing primary care house calls, as you just mentioned, with homebound older adults. And in each of those, the environment or the home environment or the lack thereof was so important for their health in terms of risks and abilities. And going into people's homes who were older and low income and maybe have lived in their house for 50 years and it's partially fallen down. As a nurse practitioner, my immediate thought was how I'd been trained, which was to think about their blood pressure or their diabetes. But to have someone drop the keys out of the window to me because they can't come down the stairs, or to watch someone go up the stairs on their hands and knees, you know, just as a person, it's just so impactful. And you realize, oh my goodness, what am I doing thinking about their hemoglobin A1C or their blood pressure? I should be thinking about their overall health and their abilities, and that functional ability, like things being able to get around one's home or leave to be involved in a community event, is underneath everything that that we care about as health, and that the managing people's conditions is obviously very important, but is usually for most of us the secondary after being able to move around, get dressed, get clean, eat.
Yeah. So do you have any tips for us as we, now you're a program designer, you're a researcher, you're an advocate, and you don't practice as much in the field? What are some tips about making sure that those who we serve remain centered and focused in our work and drive it all?
That's a great question. And for me, what I try to do is learn a lot from current programs that are we'll be talking a little bit about a program called Capable. And so talking with the nurses and occupational therapists and the handy workers about what they're experiencing and learning. And I get a lot from working with my students too, who are not patients, but there's a similar therapeutic rapport.
Yeah, oh, that's great. It's important. So let's talk a little bit about Capable. A lot of your research and your programmatic work is around the intervention called Capable, and it's one that I know a great deal about because we are replicating Capable in Central Texas through some support from Johns Hopkins, and we're really excited about that work. But for those who don't know about it, I would love for you to just share and tell us about the journey, and both a little bit about how Capable came to be and then what it actually is in terms of an intervention.
Great. So thank you. As you mentioned, my house calls experience, and through the course of that, I thought about what could we do, and I had a few patients during my time of treating them who moved to much more supportive environments. For example, someone who hadn't been able to get into her kitchen except for on her knees, moved to a senior building where she could get all around, and it was clean and new. And I was able to take her off of 2 of her blood pressure medicines and 2 of her diabetes medicines. And she was in the same body that she'd had, several months prior. And that was such an aha moment for me about someone's environment. And the environment itself alone isn't enough, but to be able to change one's environment so that it can fit what one needs is really important. And so the Capable program it's a 4-month program. It's with occupational therapy, nursing, handy worker, and most importantly, the older adult. And that is because it's completely based around what the older adult wants to be able to do to be able to age at home. You likely know, and probably the listeners know, that the vast majority of older adults want to stay in their home or in the community rather than move to a nursing home or assisted living. But often very small things are wrong with their home or weak with them, or that just kind of need a little tune-up, but it's not really for us to say what they need to be able to live there. So sometimes someone will say, I want to be able to take a bath. I want to be able to get my mail, it falls down to the floor. I can't reach down to get it, and small things sometimes. I want to be able to I can't button the buttons on my shirt. And so the Capable works so that we address only those things they identified after a big assessment from us. And as I mentioned, it's 4 months long, and it saves about 7 to 10 times what it costs. And that's because it reduces nursing home admission and hospital admission, both of which are things that most people really fear. So it saves money for other purposes that the society can use on, and older adults love it.
Yeah, thanks, Sarah. I'm glad you started to mention some of the evaluation findings from Capable, which were really striking to me when I first saw them. Although it's interesting because when I first read about the intervention, and in some ways I didn't even feel like I needed to hear the evaluation because it was so fundamental, right? You would sort of assume that it would have this effect, that if you were really kind of working from client-directed goals and having an RN, an occupational therapist, and a handy person really working around those goals, that there would, almost logically be a great impact. I recently read an evaluation of a Meals on Wheels program that just had people calling older adults in their homes without any real protocol, just talking to them, and it reduced depressive scores. So, I mean, some of these things are inherently fundamental that you would think, engagement would really help. But your research has really moved beyond that. So I'd really love for you to just share a little bit about, the rigor of your research, and in addition to some of the indicators that you share, just a broader range of some of the impacts you've been able to show.
Sure. So similar to you, when we started it, I was hoping that it could, that it would help. And I was hoping that it would be able to kind of break even, that it would cost some and save some. But what we found is that it cuts in half people's disability, which is really pretty unheard of in other interventions. And it improves 75% of the people improve in their disability. And for most of the others, they stay the same, which is actually kind of a victory because this is over time and with low-income older adults. And the kinds of things we measure are what people call activities of daily living. So those are things like being able to bathe, dress, groom, walk across a small room, and instrumental activities of daily living. Those are things like getting food in the house, managing your medications, and light housework. And together, those are the kinds of things people need to be able to do to age in community. So if you are, you may have a collection of chronic conditions like COPD, chronic obstructive pulmonary disease, or high blood pressure, or diabetes, but it's the not being able to bathe, or the falling, or the unable to dress yourself that winds you up in a nursing home. And also, this is underknown. People don't know this as much as they should, but having those same functional difficulties make you much more likely to be hospitalized as well. And medical system tends to focus more on the chronic conditions, but it's the functional limitations with the chronic conditions that make someone more likely to need to be hospitalized. So although Capable intervenes on things like bathing or whatever else the older adult wants to be able to do, get outside to hear the birds, whatever it is, that non-medical, we're changing real medical outcomes. People's pain improves, their depression improves, hospitalizations in nursing home, as I mentioned, quality of life. And in terms of the rigor that you asked about, we've had randomized controlled trials, which is the gold standard where, someone volunteers and they'll say, I'm willing to be randomized to getting Capable versus something different. And so that's the highest rigor, because you're not just getting people who are willing to volunteer for something in your program, which sometimes can be a different kind of person. It's been expanded to other places. Capable's now in 33 places, partly thanks to generous funders like yourself. And in the results from those early places, the results are almost exactly the same. And so, in the beginning, I worried a little bit that maybe we just had fantastic clinicians, and what were we going to do when the next first site started it? And luckily, we didn't need to worry.
Yeah, that's always a challenge, right? To maintain fidelity and to ensure that you can really replicate something at a larger scale in different areas. That's great. I did want to highlight that point. I hadn't thought about it too much around the value of just being able to maintain the ability of an older adult. And it's been a challenge for us in our aging program as we evaluate, because we're evaluating people who are increasingly experiencing more and more disability, and we serve them. So I think that is a critical piece of it, in addition to the improvements that you find.
And one of the aspects of Capable that I often forget to speak about, but is very true, is that Capable is almost like an engine for self-efficacy, meaning an engine for being able to approach future challenges. Because of the way that it's designed, and I want to say that it was adapted from the ABLE program, which Laura Gitlin and colleagues had already developed, and then we adapted it to add nursing and home repair. But because of her work, we adapted this book for all of Capable. The older adult works with either the occupational therapist or the nurse, or both, to brainstorm and make small action plans about the goals that they are interested in. And then, our resources in terms of what the clinician sees and notices and suggests and what the handy worker does are completely based around what the older adult had come up with. And that's important because that means that they're seeing themselves as someone, that some people would call it with agency, or someone who has, ability to make things happen. And we find again and again, people will call us later when the program's over and say, I had a new problem, I had brainstormed and I wanted to tell my OT about it. And so we see Capable not just as being a form of program, but really being kind of lifelong, setting people up to age and adapt. There's so much adaptation in aging. You're constantly, things are changing. And to be able to have a mindset of, oh, I think I can figure this out is very different than, oh, my world has fallen away from me. And as we've seen in this year with the COVID-19, so much adaptation needed. And the other aspect of the self-efficacy is that the items that the handy worker provides for the older adults that are also based on the person's goals serve as visual cues, as visual reminders of what the person wanted to be able to do. And so, for example, if they had previously fallen before, what they want to work on is not falling at night when they go to the bathroom, there will be structural things we will do, for example, grab bars. But part of what they'll do is they'll work with the nurse on strength and balance and the OT on how to get in and out of the bed. And so if someone wakes up in the night and they put their legs over the bed to stand up, if they have a bed rail right there that cues them, oh, right, I was going to sit here for a minute before I stand up.
That's right.
And so all of those work together to keep Capable's lasting impact. So we're not surprised that it saves costs for 2 years out after Capable, even though people continue to face new challenges.
That's such a great point. And this is an issue that our board raised when I first brought up the intervention, because it is a time-bound intervention of 4 to 6 months. And they were sort of concerned of like, well, what happens, after that? What else are we going to do for them? And part of what I was making the case for the model is what's so great about Capable is you can take on new clients and sort of serve many more clients this way, because you kind of have a rolling opportunity to engage with Capable. But then there is that piece of it's long enough that you really build some real new behaviors and that sense ability to take on new challenges that you identify, right? That sense of agency.
Exactly. And we on purpose space the visits with the occupational therapist and the nurse out. So they're 3 to 4 weeks apart. We on purpose do that so that the older adult is in charge of making the changes in between the visits. It's not a weekly visit or something where they're just waiting for the clinician. Really, they're in charge, and the nurse and the OT are almost like consultants in that relationship.
Well, Sarah, you started to touch on a few specific examples of like what Capable looks like, because since it is client directed, it's different for any client because everyone's goals are different about what they want to achieve. And for me, those stories are some of the most inspiring. The research is great, but what I really love is a case study, about learning what people experience. And I have the privilege of talking to some of your colleagues, and they share new ones with me all the time. And now I'm hearing them from our Austin clients, and they all inspire. But I thought maybe you could share a few to give the audience just a sense of the sort of variety and different nature of what are some of these client-directed goals and how they get carried out.
Sure. So one I'm thinking of is a veteran, and he lived by himself. He was in chronic pain, and he had a completely, what we would say, flat affect. What we mean is, kind of a depressed face. He was on dialysis from end-stage renal disease, and he moved around his house in a wheelchair. He only left his house for dialysis, and this was pre-COVID. And what he loved to do was sit on his back stoop, but his grown grandson had to lift him up and out of the door when he visited. And he was skeptical at first, and when you're in pain and depressed, it's very hard to want to try new things. But the approach of Capable is so much about what the person wants that he gave us a chance. And he identified he wanted to work on his pain and 2 functional things. He wanted to be able to shave standing up, And second, he wanted to get out his back stoop to listen to the birds without needing to be lifted. He was too weak to shave standing up, and the shaving cream and water would dribble down into his lap, and he couldn't maneuver the wheelchair or his body up onto the stoop to listen to the birds. And this might seem like a small thing to your listeners, but they're really immense if you think about a daily life. And so we addressed his pain and his strength and his balance. We installed grab bars around his sink and around the exit to the back stoop. And by the end of the 4 months, he could stand shaving, which was just a huge dignity thing for him. He could also get himself up over the stoop without waiting for his grandson to visit. And importantly, we did not push on the depression at the beginning. We did not say, well, we think you're depressed and look at that. We didn't address it at all because he didn't raise it. But through these different actions, getting stronger, being able to get outside, being able to stand, his eyes had a twinkle in them, by the end of the 4 months. And he had started to go out to community events besides just dialysis. And so to me, I think of this as, if we use our clinical expertise and address the home environment, but it's all based about what the older adult wants, because he didn't really want us in the home, and he was just thought there was nothing that anyone could do. I also think about him in terms of being a nurse practitioner. If he had come into my office, prior to Capable, in a wheelchair, in pain with a completely flat affect, I probably would have just looked at his medication list and what his conditions were and write in his prescriptions, make sure he's not in any real danger. And in the 15 minutes that I would have, that's what I would do. Yep. But now he can engage in primary care better. He can get around. And so we think of Capable as like the real primary care, the foundational to primary care, because he can, just some of your listeners may not be so interested or knowledgeable about aging, but older adults are real natural resources. And someone like him, maybe now he can be advising a small business, or he can be taking care of grandchildren, maybe, or, the more, we're not meant to have 20 years of being inactive or just thinking about ourselves. That's not how we evolved. And so if we can have Capable and other programs like Meals on Wheels and other programs can help people develop a sense of agency and an ability to engage in the community, there's so much potential to unlock.
Yeah. It's such a good example of client direction, because yes, I don't think any nurse practitioner necessarily would have said, what we need to do is help you figure out how to shave and make sure that you can get out to your back stoop. But clearly those were fundamental to his self-esteem and to his mental health and his well-being. And they were motivating factors from addressing the issues of balance and movement and all those things that he needed to do around function. So it's
right. And if we had gone in and said, you should do these exercises, because then you'll be able to, everyone is sick of being told to exercise more. But when it comes from the person's, what they want to be able to do, it's very different.
Right. The exercises are a means to those goals that he has directed. Yeah. And all of a sudden they have meaning to him, right? They're not something you're nagging him to do. They're something that he can do to achieve his goal.
Right. And just along the theme of building people's self-efficacy, we've had plenty of people who are smokers, and we don't make it a goal to tell them to stop smoking. If you're 80 and you're still smoking, you can bet at least 1,000 people have told you to stop smoking. But we do find that when they set their goals, at the end, pretty often a smoker will say, I see that I've been able to change things. Now I'm going to try to quit smoking. Yeah. And if we had said from the beginning, oh, let's talk about quitting smoking, that wouldn't have happened.
Right. But they've been able to do other small changes.
Right.
See that that's possible. Going back to that sense of agency.
Right.
Yeah. That's great. I wanted to talk just a little bit more about this piece around self-efficacy and client-directed goals, because it's not the way that we traditionally work in our healthcare systems. What is it, what is it like to introduce an intervention that is really based on client direction and client goals? It feels like there needs to be some work done there with our service providers, with our programmers, even with your funders, maybe.
That's a great question. I think that the world is moving towards at least an indication of thinking it might be important. If you think about, people talk about like patient-centered medical homes, but often what that actually means is convenient for the patient, but we're still telling them what to do. And also, I think it's time to call patients people, because that's what we all are. And it takes away some of the hierarchical nature, that really the people who have the issues that we're talking about should be in charge, and we should all be consultants. And I think that there is more than lip service in a lot of areas for patient engagement. But it's definitely part of the innovation and strong theme of Capable, and I think that it adds to the the other programs that are trying to work hard in people's goals. Laura, the chronic disease self-management program is a lot about self-directed goals, and there are definitely other programs that work with goal attainment, but I think we have taken it to another level in terms of the evidence that we have, and also the kind of almost radical nature. We don't do anything unless it's what they want to do.
Yeah, that makes sense. Well, you talking about some other programs made me want to widen the scope a little bit and talk a little bit more for our audience, some of whom don't support or fund a whole lot of work with older adults, and would like to think a little bit more about Capable is just one of many ways to support older adults as they age in place, and would love to hear what you think about what are some services, some strategies, some models for us to keep in mind when we do think about serving older adults, helping them live safely and independently in their homes, helping them sort of continue to achieve their goals for function and well-being.
Andrew, there's many wonderful programs for older adults to age in community, some of which work together and some of which are more on their own. Big shout out to Meals on Wheels. I think Meals on Wheels is fantastic, not just program, but also infrastructure for other services. And as you know, Meals on Wheels is all over the country. And in Austin, for example, they offer, home modifications, and they actually offer Capable. I think other models. So a lot of around the country, there are organizations called villages that I think are important and will become more important, where older adults themselves band together to figure out what services they can provide each other, kind of as a barter, and also they pay into it to be able to receive other services. I think it started in really wealthy neighborhoods and spread in the kind of the wealthiest neighborhoods in different cities. And I think that they're working hard to try to figure out how to make it scalable with all kinds of neighborhoods. I think also there's a really wonderful new model called Care House, which is CAREHAUS, developed by colleagues at MIT, which is a co-housing model that is not just any old people coming to live together. It's people with disabilities, potentially older people with disabilities, and care providers and the care providers' kids, so that everyone lives there. And it's designed with common spaces and a lot of thoughtful architectural design, and the direct care workers get equity in the building over time as sort of a pension kind of idea for them. So I think there's a lot of potential with that. There's one just being built now in Baltimore, and there's one that they're designing in Houston. So I think, and then of course there's many other kinds of programs. It's going to take an all of the above strategy. And I think the baby boomers will make sure that, that there's all kinds of ways to age. Of course, there's a lot of promise with technology, but I think we're still figuring out technology's role in terms of, not just having fancy sensors, but what is useful with technology. But I think that, even just with, maybe with Meals on Wheels, if people can pick what meals they want more, I think that there's going to be more and more personal choice and tech-enabled solutions or tech supplementing programs.
That's great. And while we're talking about sort of the landscape of ways to support older adults, I think it's really important for us to also just reflect on the fact that while we've had more and more innovations and really kind of a mindset shift around how to support older adults as they age in place. We've also had this pandemic over the past year that's grossly disproportionately impacted older adults and really been very difficult for older adults, and also really, not only exposed inequities related to older adults and health by the way that the virus has impacted them and their risk for serious illness and death, but also the equity among communities of color and older adults of color and how it's impacted them too. And so I wanted to ask you, as someone who's been working in this field during this pandemic, what you've sort of learned from and reflected on in terms of how COVID has really impacted your thoughts around aging and physical function and social isolation.
Yeah, those are great questions and kind of unanswerable in some ways.
Yeah.
I think that, COVID has impacted everyone tremendously. And then the intersection of race and low income and aging has been, even more traumatic for people. Also, we've been in this period of racial reckoning. Our country was, founded on stolen land and built on stolen labor. And we have not been able to jettison the idea that there's a hierarchy to human value. And I think that we're in another period of trying to reckon with that and understand how to change that. But those two together, I think, have been really traumatic for big sectors of society. We've seen so much just extreme social isolation with people. And I don't really have a good answer beyond, what anyone else would say probably, but just we cannot think, oh, we're past the pandemic.
Yeah.
Just because some people have gotten vaccinated. And, I think as we record this, about 20% of Americans are fully vaccinated, but that's a lot of adults. That's a lot of people who are not. Yeah. And I think we're doing too much in terms of having big sites at football stadiums and not enough door to door finding the homebound older adults.
Absolutely. It's a huge challenge. And yeah, I'll just share a reflection about the equity piece. I mean, I'm always reminded that the older adults that our foundation supports and the organizations that serve them, these are a lot of our older adults who are Black and Latinx. They lived through Jim Crow. They lived through severe racial segregation. And while, some of them have, lived through and have experienced some progress, they, owned property that was redlined. They went to schools that were inequitable and experienced racial discrimination. So I think it's really important that particularly our older adults have experienced the most egregious forms of racism and continue to bear that. And so it's an important reflection for the limited progress that we've made. Those inequities are particularly stark for older adults.
Absolutely. And even within the same job title, when I was a nurse practitioner seeing older adults at home, I had a number of patients, people whose house I went to, who had been janitors or house cleaners. Yeah. And the ones who had been house cleaners for a family had no pension at all, right? Families don't have it's not part of what they do, right? And it's not part of how our government is set up. And so a family might send a check at Christmas, thank you so much, thinking of you, kind of thing. But the ones who had been janitors in a school system had Blue Cross Blue Shield and great benefits, and that's because they've been part of a union. And it was this, if you think about it, it was the same like educational preparation or skill set. And I'm sure they could have done more different kinds of work if we hadn't been during Jim Crow. But even within that, there's just equity for whether someone has just a family employer versus a system employer.
Absolutely. Absolutely. We're getting close to wrapping up, but I wanted to kind of end on one more theme that I wanted to talk about, which is that, for me as a funder, a big challenge for me is the effort to scale up interventions like Capable, things that I am completely committed to and we find so much value in. But the reality is, since we're talking to funders, you know, me as a donor right now, I'm funding about 120 clients a year who from our foundation supports local nonprofits to serve 120 clients to receive Capable each year. And so we were never going to grant our way out of, you know, providing this service for so many that need it in Central Texas. And so, you know, a big challenge for us at the foundation and working with y'all at Johns Hopkins is figuring out how to identify managed care organizations who will see value in this intervention and fund it. How can Medicaid identify this as a reimbursable piece? How could Medicare Advantage add Capable as a supplemental benefit? These are so the hard work is what I call it. You know, it's easy to
Right.
fund a project. It's easy to do a call for proposals and fund nonprofits to do this important work, but there's so much more work to be done around really addressing this work systematically, that when we find really important interventions that really do save money and change the lives of older adults, you know, how do we scale that up? So I guess my question to you is, you know, how do you see philanthropy's role in that? What is, you know, what for you as a researcher and a program intervention specialist, designer, and advocate, what's your kind of call to action for philanthropy to really kind of help you in really scaling this work up at a larger impact than it is?
Well, thank you for that great question. And I think you're a real leader in this, because I think traditionally we develop and test programs initially through research usually. And then there's, after that, there's a, you know, philanthropy might get involved, or maybe they get involved in initial testing, but traditionally philanthropy gets involved in what new idea is there that there's some evidence, and then let's see where we can fund it. And then, but they're not really in the sustainability mode usually. But to be sustainable, you either need a market solution or a policy solution, or ideally both, right? That the policy creates a market. And I think you're such a leader in trying to get Capable to that next level of who do we talk to, whose doors do we knock on, who needs to see the evidence? Because if just having evidence was enough, that would be great. But it's clear
We'd already be there.
And
we
so,
have the evidence. Ask Sarah if you'd like more evidence. She has plenty.
You know, we published 25 papers, and still only about 2,000 people in the whole country have experienced Capable. And there's millions and millions of older adults who could benefit from Capable. So I think that in terms of what can funders do is help on that next level, is help think through when they're funding that philanthropy level, what are the outcomes that stakeholders care about? All kinds of stakeholders, you know, what does the press care about? What do older adults care about? What would Medicaid, a state level organization, what would a private organization, what would Medicare care about? And we're working on a kind of a multi-pronged policy push the government to allow Capable to be prescribed as a fee-for-service Medicare benefit, and to make it easier for Medicare Advantage plans to put Capable into their bids to CMS that they have to do yearly. And Medicaid, which, as your listeners know, is a 50 state solution, because every state has its own Medicaid program. Medicaid has a lot of money to save and a lot of benefit to save from Capable, because the people in Medicaid would be more functional and could get around and would not be using a nursing home as much. So, but I'm just a pointy-headed academic. And the funders are much more connected and have whole networks of people that they work with. I think another, besides just like literally knocking on doors and making the case, funders often fund, collections of evidence or best practices, and those are looked to sometimes by other funders or by policy. And just as one example, Capable was featured in the Better Care Playbook that several foundations gathered together to fund. And from that, Village MD, which is a primary care practice based in Houston and several places around the country, came to us, wanted to do Capable. So sometimes it's just highlighting best practices, but I think working together to make common sense solutions make sense for policy players is a great role for philanthropy.
That's great. Thanks, Sarah. All right, we have our marching orders. All right, so I want to finish up, and we're kind of at time. So let me ask Sarah, just any final thoughts about, you know, some of the important themes that we shared today, and things for, you know, this audience as donors to think about as they consider, you know, how do we support and empower older adults to age in place, to live with dignity and respect and well-being.
Well, thank you. What I'd like to do is circle back to some of the equity comments that you made. Our newest project, separate from Capable, is to try to understand the impact of living through Jim Crow, essentially, through education, all the domains of structural racism. So education, income, credit, and wealth, policing, civic participation, all of those. And we're doing it by understanding where people have lived throughout their lives, from where they were born to a teenager to midlife, and try to understand through matching lots of data sets to that, what their experience has been, and then how it relates to risk for dementia or cancer or heart disease. And I think that we now have statistical you know, prowess enough as a society, and also the want to, as people say, to try to figure out and change the impact of inequitable lives.
Thank you for that. It's so important to look at that and document it. We know from the research on adverse childhood experiences how impactful trauma is, and these experience of structural racism and systemic racism are trauma as well, and I would imagine have very similar impacts on long-term health and well-being. So I look forward to the research, and I look forward to the continued conversation on this format, or maybe sometime soon in person with the audience. So
that'd be great.
On behalf of myself, I want to, and St. David's Foundation, I want to thank Sarah for being a part of this great conversation, and thank you for being such a great partner for us in our work with older adults in Central Texas. I want to thank Grant Makers and Health for affording us this opportunity, and the audience, and particularly thank Colin for organizing this and his entire team. We appreciate the opportunity to have the conversation. So thank you very much.
Thank you.